Okay, good morning, good afternoon, or even good evening to you. Thanks for joining me on this webinar on stigma and MAT. I'm Craig LaFay, and I'll be talking with you all for the next hour or so about the results of a survey we've recently done at RTI on opioid-related stigma. And just as a little background for me, I'm the lead change designer at the RTI Center for Communication Science. My background includes doctorate in clinical psychology, postdoctoral work in public health, and for the last couple of decades, I've been very involved with particularly applying that to communication and marketing programs for a variety of issues. In the last couple of years, a lot of that has been focused on opioids and on stigma, as you can see here. First, a couple of housekeeping items. This webinar is brought to you by RTI International, and we will be having a Q&A session. Actually, we'll have a couple breaks during the presentation where you can submit questions by using the bottom left-hand side of your screen and writing those in at any point during the presentation. We'll try and get to as many questions as we can throughout the webinar, but I've reserved at least the last 10 minutes to get through most of them. Also, you can find a PDF of the presentation and additional resources under the headshot image that's also up there on the left side of your screen. And if you do need any help or for any assistance, please email Melissa Pangaro at mpangaro@naccme.com. Now, this is brought to you by the Psychiatry and Behavioral Health Learning Network. And for those of you who are looking for inadequate credit information, you have to watch the program all the way through the Q&A section at the end of the presentation. And in red letters here, do not leave your console. Continue to stay on the platform, and at the end of the webinar, you'll be automatically redirected to an evaluation landing page. If this is your first time attending a webinar in 2019, you will need to create a NACME account when you are first directed to the landing page. For all subsequent webinars you attend, you already have an account and you just need to log in. After completion of the evaluation, you will be able to download or print your certificate. And again, NADIC credit is only offered for the live broadcast. So what I'm going to spend some time talking about today is first what we mean by stigma, the survey methodology, our survey results, including for the total sample, and then analyses we've done of differences among respondents who lived in either rural, suburban, or urban areas, the implications for public education objectives, the cautions for anti-stigma campaigns, and finally a focus and selection of anti-stigma campaigns based on the results we have. So it's difficult to go to any presentation or read any report these days when it comes to working against the opioid crisis, where someone is saying in one way or fashion, we must reduce stigma. Some of the more recent calls for reducing stigma are from the National Academy of Medicine, Department of Health and Human Services, Pain Management Best Practices, Interagency Task Force, the President's Commission, and the National Governors Association. As I said, there are literally dozens more. But the question that we have is, what do we mean by stigma? Some of the early work I did in this area was with the Special Operations Command, Department of Defense, where there's a very high, if not number one priority, to reduce the number of suicides and to increase the number of soldiers and veterans who are seeking behavioral health care. And the General Accounting Office was able to do a survey of all the Department of Defense policies that specifically relate to reducing stigma. And what they found, and what I also see, is that there's very little specificity about what people refer to when they use the word stigma. And even more important, what kind of behaviors are associated with stigma. And I was at the recent RX Summit and heard many people use this phrase, we must reduce stigma. And at best, what they offer is that we need to talk about it more. And so in this next section, I want to kind of explore a little bit more what stigma really is based on the concepts and the research in the area, not just for opioid, but across many other health issues as well. So the process of stigma is actually a very active one. First, people distinguish and label differences about people who suffer from prescription opioid addiction, people who have a mental illness, people with HIV, and many other kinds of problems. They then look at these labeled persons and link them to culturally undesirable characteristics, or what also are called stereotypes. And these stereotypes are helpful because they distinguish the, quote, normal us from the unusual them, which leads to a process that's referred to as social distance. And through these processes, we then find those people who have been labeled, stereotyped, and distanced, losing status, being discriminated against, and experiencing unequal outcomes, not just in health, but also in housing, employment, and social relationships. So as we were developing this survey, these different facets of what goes into creating stigmatizing beliefs and more importantly, stigmatizing and discriminating behaviors was a focus. Many people also use stigma in a very relaxed way. Sometimes people will refer to self-stigma or the shame that someone feels because they are, in fact, addicted to prescription opioids or something else. But many times there's also the stigma that's experienced by the family of someone. And then what we have found in some of our research, and it's been replicated in research in the area of HIV and mental health and substance abuse treatment, is oftentimes healthcare providers report experiencing stigma because they work with these people in treatment and recovery. And probably in the vernacular, what's most often talked about as stigma is the social stigma, or how society or large portions of society respond to and treat someone who's been labeled as a person with an addiction or a person with a specific type of disease. And finally, there's the structural or policy forms that stigma can take, where these types of attitudes, stereotypes, wanting to remain distant from people, become embedded in various types of policies and various types of programs. And in fact, many times when people were working in the opioid addiction area, structural stigma becomes one of the great barriers to actually improving programs or improving accessibility to treatment programs. So when we're thinking about stigma, treatment seeking for addiction, and retention in treatment, these types of stigma can manifest themselves in a number of different ways. And from one point of view, is a large contributor to why people avoid treatment or don't complete treatment. And that is because stigma can undermine people's sense of self-esteem. People who think about or contemplate going into treatment might anticipate social rejection and other negative reactions, more of a social stigma. There are people who, when they're contemplating whether or not they should seek treatment for addiction, worry about the reflections that help-seeking behavior may have on their family, as well as on providers. In fact, in some of our research, we're finding that providers who start suspecting that one of their patients may have become addicted to prescription opioids actually are as concerned about the reflections that may have on them, both among their other patients as well as among their peers. And then there are also concerns about resulting discrimination due to existing laws or policies that may occur if someone identifies themselves as having an addiction or being in treatment. So I'm going to stop here just for a moment to see if anybody has any questions about this. If everyone's hearing me okay, I saw some concern about sound there. And just ask the question, is stigma a noun, that is a label or something that somebody has, or is it a verb that is an active process that's occurring not just within an individual, but among the people in their immediate social circles, healthcare circles, and larger society? Tim, I see your question there about if you can include methadone appointment on patient materials. And frankly, I don't have a good answer for you right there. Maybe someone else knows a little bit more about that than I do. Okay. Moving into the survey itself, we created the survey around 4 specific research questions. First, what evidence is there for stereotyping and social stigma among the general public? How knowledgeable is the public about opioid addiction and treatment? And here I think we kind of diverge from some other surveys you may be familiar with, in that we got very interested in how people perceive treatment of addiction. Does the public perceive that people with an addiction have access to treatment? And finally, because again, some of the work I mentioned earlier, we've done a number of qualitative studies with physicians, and what we find that they have some concerns about whether or not they might be stigmatized because they start treating patients with an addiction. And we flip that into, does the public have concerns about being treated by a provider who also treats people addicted to opioids? So we had an external advisory panel help us refine these research questions. We recruited through the survey vendor Research Now, their participant database. We restricted it to 18 to 75-year-olds. We deliberately stratified our sampling so that we would have equal representation from urban, rural, and suburban settings, so that we could do some analysis of differences among people who live in those different groups. And this is a fairly short survey designed to be completed in about 15 minutes. So I'm not going to show you all the questions from the survey. In fact, in a couple slides, I'll give you a link to where you can see the entire set of questions and the responses to the survey. But we asked 8 questions that dealt with knowledge, 3 that dealt with stereotyping, 13 questions on attitudes and behaviors related to social stigma and attitudes towards opioid treatment and perceptions of efficacy of different treatment options. We had 997 people in our sample. About half of them were female. About 12% were Black or African American, about 10% Hispanic, and the mean age was 50. And you can see I provide the U.S. estimates for the population there, but again, keep in mind that our sample is not meant to be representative of the U.S. population, as we did specifically stratify, so have larger numbers of people representing rural areas and urban areas than you might ordinarily expect. 36% had a high school education or less. 35% had household income less than $50,000, which is substantially less than the U.S. estimate. About 65% had not received any prescription opioids in the past 3 years, and at 10% of our sample were currently taking prescription opioids for 3 months or longer. Just for anybody who's got any questions about the methodology, and this is a good time to kind of get any clarifying information you'd like. And also you can download a poster session which has all the questions of the survey at this URL. And Tim, I see your questions, and I'm going to kind of hang on to those till the end because those are nice big picture questions to come back to. Okay, into the data. One of the things I'm going to ask you all to be looking at as you look at these answers is to not just think of them with your educator hat on. By that I mean, how many people got it right and how many people got it wrong, but also to think about it from your communication hat or point of view, where you really start spending more time thinking about, well, how do we shift the don't knows? And how do we move some of those people into a more correct way of thinking about things or a more positive way of viewing the situations? So as you're looking at this, just don't go how many right, how many wrong, but how many people can we probably more easily shift? The people who are responding, I don't know, and in some of these questions responding neither. So as we see here with the first question, about 55% of people say that those with an addiction to prescription opioids do not receive any type of treatment. And again, from a communication point of view, the fact that almost a quarter of the population don't know whether that's true or not is a potential leverage point. Almost 50% of people agreed that primary care docs have not been trained to treat people who are addicted to opioids. So again, you have to ask yourself, what does the other half of the population believe about this? And finally, almost half the population believes that people can get treatment for their addiction to opioids no matter where they live. And again, the question becomes, well, how do we shift some of those ideas as well? For the questions about social stigma that were particularly notable from our point of view is that most people with an addiction to prescription opioids do not receive any type of treatment, and more than half agreed with that statement. 30%, however, disagreed with it completely. Some people acted self-discipline to use prescription opioids, This is sometimes used as a question, a single question, to identify social stigma. And here we see almost 2/3 of the population agree with that statement, which again has ramifications for how people experience social stigma, as well as internalizing that and having a sense of what we call self-stigma. When we think about stereotypes and undesirable characteristics, two of the ones that come up on many different types of scales related to stigma for other types of health problems are the idea of people who have the illness can't be trusted or are untrustworthy. Here we find about half the people disagree with that statement, but then almost a third don't know whether to believe that or not, don't agree or disagree. And as you can see, very few people are actually agreeing with that. And the other characteristic that we often find with people who are being stigmatized, besides untrustworthiness, is also the notion of dangerousness. And here we find that almost a third of people agree that people on prescription opioids are more dangerous than the general population. Even more, 38% don't know whether to agree or disagree with that statement. And about 1/4 of the population does not endorse that statement. So again, in terms of stereotyping, in terms of attributions of causality, we find that large percentages of the population either endorse those ideas or, perhaps more importantly, don't really know which way they stand on that. Our questions about stereotyping were pretty straightforward. We asked people whether opioids affect mostly the middle class, the poor, or the wealthy, or whether they affect all income groups equally. And as you can see, about 80% thought that they affected all income groups equally. We asked the same question about whether it affects people living in urban, rural, or suburban areas predominantly. And again, almost an equal number of people thought that it affects all people in all areas of the country equally. We then asked a question about what racial groups are most likely to be addicted to opioids. And again, 78% thought that all racial and ethnic groups are likely to be addicted to opioids. Then we move to probably the most pernicious and also the most observable forms of stigma, which relate to discrimination. Nearly half of the population believe that employers should be allowed to deny employment to someone who's addicted to prescription opioids. Again, you see another 30% who neither disagreed or agreed with that. About a third of the population believe that landlords should be allowed to deny housing. And again, about a third disagreed with that, and about a third were in the middle. And finally, we asked whether doctors should be allowed to refuse to treat patients who become addicted to prescription opioids. Here we find about 20% agree, but we're going to ask that question again in a few minutes on the survey in a different context. Just be aware that that number is going to shift fairly drastically. And then again, the idea of social distance, which is, usually expressed by how close you would want to be with someone, in this case, who's addicted to prescription opioids. Feeling comfortable working with someone, only 20% agree with that statement. Almost 44% say they would not feel comfortable working with someone. Be comfortable becoming friends with someone who is in treatment. About half agreed with that. You can see there about a third of the population neither agreed or disagreed with that statement. And if I found out that a close friend had become addicted, I would avoid him or her. Here, only 13% would agree, and 63% disagreed. So what we see here is that as if someone has great familiarity and is close with someone prior to being addicted to prescription opioids, they're less likely to put distance between them. But as we move out on the social distance scale, from friends to coworkers, and we could have taken this out even further in terms of the relationship a person has with someone who's addicted to opioid, we would see that social distance becoming greater and greater. There's a lot on this slide, but it only relates to one question. How effective or ineffective do you think each type of treatment is for addiction to prescription opioids? And we were interested in this because there are a lot of options out there that people are aware of, and we wanted to get a sense of treatment efficacy, because we know from other types of studies that once you can reduce the stigma associated with seeking treatment, the perception of the effectiveness of that treatment then becomes the next great barrier to overcome when you're working with behavioral health care or mental health issues. So we described MAT or MOUD, medications for opioid use disorder, as medications that work in the brain to prevent opioid cravings. And the first thing I'll note there is that when we asked people prior to this question whether they had ever heard of MAT, prior to the survey, about 40% had said yes, they had, which just gives you a sense of the awareness of the treatment in the general population. But when we asked everyone what they thought about the idea of medications working in the brain, you see that about 70% perceived it as being somewhat or very effective. Very few people saying not at all effective. And again, a large proportion of people, about a quarter of the population, didn't have an opinion, didn't know. We asked them about individual or group programs, and this is even slightly higher than the MAT approach, where it's about 80% as compared to 70%. Inpatient treatment programs, again, about 74% of people thought they were somewhat or very effective. Cold turkey kind of stepped up as the one that almost a third of people thought was not at all effective. And just less than half thought it would be effective if people tried to stop on their own. Becoming more religious or spiritual, again, about 56% of the population, 57% of the population saw those as somewhat or very effective. And seeking treatment for anxiety or depression was up around 78% of the population. So even though MAT, as we described it here, can be seen as effective by 7 out of 10 people, in fact, other types of programs are perceived as being possibly even more effective than that approach. And it's something to consider as we move forward with thinking about how do we increase people seeking out, receiving, and staying in MAT. Then we asked them questions about their attitudes towards MAT. And of course, one of the ones that's out there quite a bit that we hear about is that medication-assisted treatment substitutes one addiction for another. And here we find about a third of people agree with that, but a very large 42% of people don't know whether or not to believe that statement. We then asked about attitudes towards providers. Feeling uncomfortable if I found out that he or she treated patients addicted to opioids, 34% agreed that they would feel uncomfortable about it. And probably as important, if not more important, 36% didn't know what to think about that. Now, again, as I said earlier, we repeated the question: a doctor should be allowed to refuse or stop seeing patients if they are addicted to prescription opioids. Now, in the context of asking these questions, what was 20% earlier in the survey suddenly jumps up to 36.4%. And probably even more of concern to people is that 33% of these respondents would not want to see a doctor if they knew that they also treated patients who were addicted to opioids. So that idea of stigma as it relates to healthcare providers certainly seems to be rather prevalent in the U.S. population. And when you put that together with the almost 40% who neither agreed or disagreed with that statement, you can see there could be some very significant problems for healthcare providers, especially in primary care settings, who are contemplating whether or not to get waivered and to offer MAT or MOUD to patients. Finally, we looked at rural, suburban, and urban differences in responses to all the questions on the survey. And what we found is that suburban residents were less likely to know someone in treatment for addiction to prescription opioids, only 11%, as compared to 16 and 18% in rural and urban areas. We found absolutely no differences in these three groups on knowledge items. We found that suburban residents were less likely to think that cold turkey is not an effective treatment. Found urban residents more likely to think that becoming more religious or spiritual is not an effective treatment. And there were no other differences in attitudes towards treatment or towards providers among these three groups. When we looked at the stigma beliefs, because there are a lot of suggestions or commentary out there that people in rural areas are more likely or less likely to stigmatize than other groups, we found only three real differences among residents in urban, rural, and suburban settings. When you look at this, these numbers, means in a positive direction means that they're more stigmatizing, and a negative sign is less stigmatizing. So what we find is that rural people are more likely to endorse the idea that employers should be allowed to deny employment to people who are addicted to prescription opioids. People in suburban areas also share that belief, or as strongly in that belief, whereas the urban groups are less likely to endorse that form of discrimination. Whether or not people who are addicted to prescription opioids or recovered from prescription opioids can't be trusted, you see here that it's the rural groups are probably least likely to believe that. Urban groups also less likely to believe that. And what shows up here is that people who live in suburban areas are most likely to endorse the idea that people can't be trusted. So again, that stereotype idea. And then when we look at the idea of dangerousness, we find that rural and suburban groups are more likely to endorse the idea that people who have been addicted to prescription opioids are more dangerous than the general population. So do we have any questions about the results at this point in time? Anything that needs to be clarified here? Okay, then let's look at the implications and key findings. So the first thing is that the good news is half of the public agree that addiction is a medical illness. I guess the flip side of that coin is that 48% of the public don't agree that addiction is a medical illness. So it points out work to be done there. Again, as I mentioned earlier, 4 in 10 respondents had not heard of MAT prior to taking the survey. So there's awareness issues that need to be addressed there. Although 70% perceive MAT as somewhat or very effective, other types of treatment for addiction were actually endorsed as being more effective. More people, I should say, endorse other approaches to treatment as being somewhat or very effective. One in 3 respondents agreed that MAT substitutes one addiction for another. As you said here, contrary to what it might have been some expectations and beliefs among some of you, there are very few differences among rural, suburban, and urban residents when it comes to opioid knowledge, stigmatizing beliefs and behaviors or attitudes towards treatment. So with respect to public education objectives, there seem to be at least 4 suggested by the data here, and that's increasing the percentage of people who know that someone may not receive any type of treatment, that most people with an addiction cannot get treatment where they live, that not all primary care physicians have been trained to treat people with an opioid addiction, and certainly what MAT is, and that's an effective treatment for opioid addiction, certainly needs to have a lot more attention. So responses to these items also suggest the need to reduce public acceptance and support for discrimination in employment, healthcare, and housing. The fact that these beliefs are as prevalent as they are can provide kind of a social and even a structural barrier for folks who are especially in recovery and trying to find employment, trying to get into housing, trying to get better quality of health care. Again, as I said, looking at the I don't know and the neither categories, there are a lot of what we might call uncommitted people, and especially shifting the attitudes of these people towards supporting treatment and other services for people who are addicted to prescription opioids is going to be important. And finally, we also need to increase public acceptance of physicians, or what some people are referring to as mainstreaming the treatment of addiction, especially in primary care. And then in the literature, there's a couple caveats that we come across when it comes to trying to reduce stigma. One of these is from the National Academy of Sciences, who noted that when we start trying to increase the acceptance of a biological model for addiction, we might actually increase stigma because people might perceive that the addiction is permanent, and that they may also become much more pessimistic about whether or not people can recover and be treated effectively for their condition. So while there are many people out there who are pushing for a broad endorsement of the biological model, that it does come with some potential pitfalls, as identified by the NAS. Another thing to look at if you're focusing on MAT and trying to get people into treatment for MAT is the results of another poll that was done by Politico and Harvard back at the end of 2018, And they asked the question whether or not that you would consider a friend to be effectively treated if they needed long-term treatment, counseling, and a milder opioid medicine to control their cravings, which was their way of explaining MAT or MOUD to their sample. And only 1/3 of their sample thought that that was an effective way of treating their friend. So there's, again, going to be a lot of resistance from a lot of quarters about these perceptions of how people are treated and how effective that treatment might be. And finally, I wanted to also bring out the point that when stigmatization is successful, that is when it's been pretty well embedded in the social and particularly the structural parts of society, that any element of the status quo that disadvantages people with addiction can remain securely in place. So whenever we're in the field and implementing programs and trying to get policies changed, one of the key things we have to remember that the more resistance there is to that, the more likely you are encountering stigmatization in various forms, and there's a need to step back from that and kind of understand where that stigmatization is coming from, how people are formulating it, how it's being expressed, and then how to manage it. And in terms of managing stigma, whether it's in the interpersonal sphere, whether it's with communication programs or policies, our data is suggesting that one focus of anti-stigma efforts might be to change perceptions that treatment seeking is a sign of weakness. Another key leverage point that this data made very clear to us is that perceptions of being incompetent, dangerous, or untrustworthy need to be addressed as well, because these are the drivers of the more emotional response that people are going to have when they're encountering or dealing with people with an addiction. There are campaigns going on now in the mental health area, but working with patients and families to reduce that feeling of responsibility they may have for having an addiction, the self-blame or the self-stigma, is an important focus of efforts. Getting the message out that effective treatment is available, but also that it's not available for everyone who needs it for geographic or other reasons. Again, going back to the idea of mainstreaming the treatment of addictions to opioids, the message that physicians treat addiction to opioids just like they treat other types of medical conditions, including diabetes and high blood pressure, and pick your own favorites for how to do that. But it needs to become less of a auxiliary activity that some physicians are engaged in, and something that we understand that all physicians, you wouldn't go to a physician specialist if your child has an earache. You'd go to your general practitioner, and I don't want to equate earaches with addiction, but many earaches are in fact due to an infection, and if we were stigmatizing infections in the same way we treated addictions, we'd be taking all our children to infectious disease specialists. That clearly isn't the case and clearly not necessary. We need to kind of get that same type of thinking going on among patients when it comes to their physicians in the treatment of addiction. And finally, the needs to be enforcement and review of non-discrimination policies for employers, for landlords, and physicians. I can only say that from where I sit, that I've heard lots of different stories from chronic pain patients and people in treatment about employer discrimination, even among people who are employed in addiction treatment centers. Certainly housing becomes an issue, especially for people in recovery when they may be on MAT and their sober house has a policy that you can't be taking any drugs of any kind to live there. And certainly among physicians, we hear stories weekly about physicians who are either just referring patients they suspect are addicted to prescription opioids to specialists, or they're simply referring people who present with chronic pain to pain specialists. But there is, and also it's been going on for years here about physicians, quote, firing, unquote, patients who fail to adhere to their screening programs for opioids. Okay, with that, I'm going to wrap up, and we're going to go into a Q&A session. I see there's a bunch of questions here on the page. And again, just a reminder for those of you who are trying to get the NADIC credits, don't leave this page. Continue to stay on the platform. We've got about 15 minutes left in the session. And I'm going to move to the questions. Spinning back to the beginning here. Okay, one of the questions I see here, is stigma different and harder for opioid addicts as opposed to other addictions? And it just got skipped here. As opposed to other addictions like alcohol or mental health. And there's been a little bit of work in this area. This is from Timothy Shaw. There's been a little work in this area. And from what I have seen so far is essentially no, the stigma isn't any different. It may be harder for opioid addicts as opposed to other people who are addicted to other substances or have mental health issues. But I think at this point in time, what we're learning from the alcohol addiction literature, the substance abuse addiction literature, the mental health addiction literature, and even the HIV treatment literature, is that essentially people are having the same kinds of problems in everyday life, and that taking kind of the broad approach that I've been outlining here is probably going to be a useful start. It's certainly going to take us further than we are right now with simply encouraging people to just talk about it. Another question was about structural stigma. What we mean by structural stigma is really the way that stigmatizing attitudes and stereotypes are expressed in rules and regulations, whether that's at a company level, whether that's at a city or county level, or whether that's in federal laws and regulations. So structural stigma, for example, we're talking about discrimination by landlords or by employers, that, you know, if there are not policies in place that expressly prohibit that type of discrimination, then it's more likely to occur. If we look at these policies and try and understand, you know, what their intent is, and does it express some underlying concerns about the trustworthiness or dangerousness of people who are addicted to prescription opioids, then that's an issue to address as well. The next question, can stigma ever be a personal motivator to change behavior? Can reducing stigma ever lead to an increase in social pathology? Well, that's a good question, because I've been involved now with a couple different groups who are talking about the idea that, you know, maybe we should be stigmatizing opioid use more, because when we did that for tobacco, it actually led to fewer people smoking. And I'm personally not going to endorse that idea for very long. And I don't think that experiencing stigma is going to be a motivator to the large majority of people. There will always be individual cases where that might be true. Can reducing stigma ever lead to an increase in social pathology? I expect that it probably can. Certainly, stigma is, in a way, a type of social norm, maybe a negative social norm, but a social norm nonetheless. And certainly if we were to say, increase the acceptance of people using opioids, recreationally or otherwise, you could certainly see a pathway to social pathology pretty easily. But the key efforts for those of us who work in the anti-stigma area is to address the types of stigma that prevent people from seeking treatment and staying in treatment, and prevent them from finding pathways to have a more secure and productive and socially rewarding life. Another question here is, please discuss under structural stigma how it affects law enforcement and the criminal justice system and the impact on people with SUD. And I think I've kind of hit that point a little bit. But again, where structural stigma in law enforcement and criminal justice seem to pop up for me when I'm listening to those folks talk or reading their papers is that there's just this general underlying sense that everyone who has an opioid use disorder is somehow more dangerous or less trustworthy than the average person. You can also see the structural stigma in the ways that we talk about, what should be the policy response to someone who is suspected of or arrested for or sentenced for behaviors related to their addiction. Someone asked here about what percentages of the sample were urban, rural, and suburban, and they were equal. It was 1/3 of the sample from each of those three groups. Someone asked if statistics have been taken about, I assume, opioid use and stigma among Native American populations, and to the best of my knowledge, the answer there is not to this point. This is a little bit more out of my ballpark, but why are opioids so addictive? Is there anything that can be done to reduce the addictive properties? There's a lot of work going on in that area, and there's a couple good papers in that area. I'm thinking of one by Nora Volkov and Francis Collins that was in the New England Journal of Medicine in 2018. That would be a real good source for you. And in fact, there was a paper just in the past week in the New England Journal of Medicine by authors from the CDC that also were looking at the ramifications of the CDC guidelines for opioid prescribing that goes into some of these issues as well. Another question here is, with baby boomers over 65, Medicare doesn't pay for treatment. How are they to get help other than out of pocket? And the answer is, I'm not sure how that's going to happen. But again, a timely question, because just yesterday in the journal Health Affairs, there was an analysis of patients who have sought treatment for prescription opioid addiction and have been prescribed buprenorphine. And after a lot of analysis of the national data, the bottom line is that what they found is that people who are white and people who pay out of pocket or health insurance are more likely to receive prescriptions for MAT than other types of folks. So this whole issue of access and cost is one that we're still going to be working through for a while. How do these results compare to similar results historically? If that question is about do our stigma and opioid use disorder have an historical precedent, the answer, as far as I know, is no. This is the first survey that's been done specifically on that area. If you look at other surveys that have been done over the years on various other forms of substance abuse and HIV, these results tend to line up pretty well with those. There was one survey that was done last year that looked briefly at whether or not stereotypic attitudes related to people's endorsement of different policies for responding to the opioid crisis. We used those three questions. Those three questions were the ones about whether or not it affects, whether or not opioid use disorder affects all racial groups, all income groups, or all geographic groups equally. And what they found was that the more people endorsed one of those stereotypic beliefs, the less likely they were to support different policies for a response to the opioid crisis. There's a question about whether patients addicted to opioids and continue to receive opioids from their prescribers for pain management or other things, does that qualify for a treatment? And the answer there is no. As long as if someone can be taking opioids on a chronic basis for a long time, many years, without becoming addicted to them, they can develop a tolerance for their opioids where the dosage may need to be increased. But addiction is defined in a different way. So unless people have been diagnosed with an opioid use disorder, and whether they've accessed any form of treatment, whether it's the question here included detox facility, a rehab treatment, or an outpatient treatment, that is not considered someone in treatment for an opioid use disorder or for an addiction to prescription opioids. Another question here, should individuals on MAT and those who are abstinence-based be in treatment together or in separate programs? And, this is one of the places where stigma is showing up quite regularly. And again, at the RX Summit last week, I wound up talking with several patients who sought me out to talk about their own experiences of being on MAT, but also, and I'll say trying to attend Narcotics Anonymous or Alcoholics Anonymous meetings, or seeking housing in recovery houses, halfway houses, and finding a lot of stigma there. And their sense is that people who are on MAT probably need to be in a different type of group because they simply feel like they can't talk about problems they're having with their treatment. When you have a group of mostly abstinent people who are, in their minds, judging them and encouraging them to get off the drug and kind of just do it on a 12-step type of program. And the problem we have is that there simply aren't those types of support groups available, at least among the people who I've talked to about it. So anecdotal evidence only, but certainly coming from people who have lived that experience, I'd say that there probably needs to be some separation. Okay, and that's all I'm able to get to. Sorry, I probably left 2 or 3 off here at the end, but thank you very much for your time, for your attention, and I hope there's something that you've heard this afternoon that might inspire you to greater efforts and more innovative efforts in your work. Again, for those of you who want your credits, stay online, and we'll be moved over there in just a moment. Thank you all very much. Bye.